Hello again. In this video, I'll show you two signs that will help you to detect even a teeny tiny pancreatic head cancer. So let's start with the first case here. We need to zoom. Okay, so this is the first case. Okay, so the first sign is this main pancreatic duct dilatation, main pancreatic duct dilatation, as well as common bile duct dilatation, common bile duct dilatation, common hepatic duct dilatation, dilatation of the intrahepatic biliary radicals. So, what is this? A combined dilatation of the pancreatic as well as biliary ductal systems. So dilatation of two ductal systems at the same time, the pancreatic and the intrahepatic and extrahepatic biliary ductal systems are a very strong sign of pancreatic head cancer. So how to know that this is the common bile duct and it's not the pancreatic head cancer? I will tell you the trick. I will tell you my trick here. If you go with the common hepatic duct, okay, and when you go downwards, okay, you will find that the common bile duct, if dilated, it will be stuck here in the space between the pancreas and the duodenum. The common bile duct will be seen here in the space between the pancreas and the duodenum. Here's the duodenum. This is the pancreas and this is the mass. This is not the dilated duct. Here's the duct. Can you see it? It's a kind of stuck here. Here's the mass. Here's the dilated common bile duct. Dilated common bile duct. And if you go with this duct, it will communicate with the intrahepatic biliary ductal system. Okay, so this is the start of the main pancreatic duct, and this is the common bile duct. Okay, here's the mass here. So the second sign to confirm that this is a pancreatic mass or pancreatic cancer. This is a pancreatic cancer, not a mass. This is a pancreatic cancer, is that the pancreatic cancer is non or hypovascular. It's poorly enhancing lesion compared to the avid enhancing pancreatic head. This is the second tip. Poorly enhancing lesion appears dark compared to the avidly arterial enhancing pancreatic tissue. So this lesion is an ill-defined hypodense non-enhancing lesion. is seen in the head and the uncinate process of the pancreas. The uncinate process of the pancreas is seen, this is the extension, is seen between the aorta and its branch, which is the superior mesenteric artery. So it extends in between the aorta and its superior mesenteric artery branch. So this lesion is taking the pancreatic head and the uncinate process. Okay, this is the lesion. It's ill-defined, as you can see here. Okay, so this is another example of pancreatic head carcinoma on contrast enhanced CT scan. This lesion is ill-defined, poorly enhancing lesion. This is the normal pancreatic tissue, which is avidly enhancing. This is poorly enhancing lesion. Hypodense non-enhancing lesion in the pancreatic. This is the pancreatic head and neck. Here in the pancreatic head and neck. It's not taking the uncinate process. Okay. So this lesion with its non-enhancing pattern suggests that it is pancreatic cancer. Okay. And the second sign to detect that this is a pancreatic head cancer is dilatation of the pancreatic duct. This is the dilatation of the main pancreatic duct. And if you go up, you will see that there is also associated dilatation of the, I think this is the common hepatic duct. You will see the dilated common hepatic duct, then the dilated common bile duct. It will be seen here when you go upwards, and you will see also the dilated common hepatic duct and the dilated intrahepatic biliary radicals. So I hope this information will be helpful to you to not miss any pancreatic head cancer. So after describing the pancreatic head cancer, you need to look for any enlarged local or abdominal lymph nodes. Okay, you need to look for any metastasis to the liver, parenchyma, no parenchymal metastasis. You need to look for any bony lesion, no bony lesion. So you need to exclude any lymphatic parenchymal, hepatic parenchymal, or bony lesions or bony metastasis. Okay, and after that, the interpretation will be the findings represent unlikely, because you need to confirm with biopsy. Okay, the findings represent a likely malignant mass in the pancreatic head, in the pancreatic neck, in the ampulla of the pancreas. So a likely malignant mass causing obstruction of the pancreatic and the biliary ductal systems with resultant dilatation. The principal diagnosis, pancreatic head or ampullary carcinoma. The differential diagnosis, it's very important here. The differential diagnosis is very important. Why? Because this lesion is poorly enhancing. However, this lesion is avidly enhancing. The neuroendocrine pancreatic tumor as pancreatic insulinoma, neuroendocrine pancreatic tumor as pancreatic insulinoma. These lesions are typically hyper-enhancing and well-defined. You will see hyper-enhancing mass, very well-defined and hyper-enhancing mass in the pancreatic parenchyma. And once you see neuroendocrine pancreatic tumor, you need to look for the commonly associated pituitary and parathyroid adenoma. All of these tumors are associated in multiple endocrine neoplasia type 1, as if the multiple endocrine neoplasia that I heard it from a doctor one day. He told me men type 1, in men type 1, the patient will be studied with adenoma in his body. You will find adenoma in the pancreas. You will find adenoma in the pituitary. You will find adenoma in the parathyroid, as if he's taking benign tumors shots. Someone is shooting him in his pituitary, someone is shooting him in his thyroid, give him a shot in pituitary, a shot in thyroid, a shot in his pancreas. So he has now pituitary adenoma, parathyroid adenoma, and pancreatic insulinoma, and he's typically now men type 1. So don't miss the neuroendocrine pancreatic tumor as a differential diagnosis, okay? The management, how to manage a case of pancreatic cancer. Urgently alert the referring physician of the finding and recommend what? Recommend biopsy. I can tell the patient, hello, you have a mass in your pancreas. Okay, what is this? We still try to find, okay, but we need to take a biopsy from your abdomen. Okay, so the good news is that the pancreatic cancer can be biopsied by endoscopic ultrasound. You can go through his mouth, okay, and go through the stomach and then the duodenum, okay, because the pancreas is closely related to the duodenum, as you know, so like this, okay. So it need first to be biopsied by endoscopic ultrasound guided biopsy, and after that the biopsy for tissue diagnosis, okay, and after that it needs to be resected. So you need to recommend discussion at a hepatobiliary MDT to guide management, or to guide to guide management, which may include surgical resection, or to look for the amenability for resection, for further management, or amenability for resection of the tumor. So you need to remember that if you find a pancreatic cancer, to whom will you refer the patient? To a hepatobiliary MDT. Okay,